My name is Jenny Brott, and I am a board-certified clinical specialist in oncologic physical therapy. I will be discussing management of the patient just before and after their breast cancer surgery. Pre-surgical assessments should target those patients who will be at greatest risk for problems after surgery. That would specifically be those patients who have a planned axillary dissection and will likely be receiving radiation treatment. Many of these patients are also receiving neoadjuvant chemotherapy. At the time of the assessment, arm volume should be taken on the affected and unaffected side and converted into volume in milliliters. If available, bioelectric impedance spectroscopy can be very helpful as well. An L-Dex ratio that changes a little bit after surgery can trigger intervention with a compression sleeve. Those patients receiving neoadjuvant chemotherapy should be screened for fatigue, neuropathy, balance impairments, and difficulties with functional mobility. Provide education regarding immediate postoperative care before that patient returns back to you, likely 7 days after surgery. Early mobilization is mobilization within the first 3 days after surgery, and late is considered 7 to 14 days after. This has been evaluated in literature and found that early mobilization might help with range of motion at the 2-month point. However, early mobilization can also contribute to greater drainage. It's important for drains to be removed as soon as possible. And so what we do generally is in the first 7 to 10 days, we just use functional motion, self-cares to the head. And then after 7 to 10 days, progress to low repetitions within tolerance, even when the drain is in. Encourage patients to use a normal posture, relaxing their shoulders at their side when they walk. Discourage bracing of the arm against the side. Work with your surgeons to develop protocols that everyone agrees on. Range of motion, reclined, can help avoid substitution patterns. Encourage flexion, abduction, lateral abduction, and external rotation. Lymphedema education is best done following surgery. It is important to teach patients the pathophysiology of the lymphatic system. It's important to educate your patients about their risk factors. Those with an axillary dissection and radiation treatment have about a 20 to 22% risk of developing lymphedema. Their surgery is not within their control, but living a healthy lifestyle is. So reducing their risk of developing an infection on the affected side and also keeping the healthy weight is important. Those with a sentinel node dissection have a much less risk of lymphedema, and so we generally don't educate them the same way as we do those who've had an axillary dissection. Behavior modifications, such as avoiding blood draws, injections, and venipuncture on the same side, have been widely distributed. It is important to note that in the literature, blood draws, injections, venipuncture, and air flight have not been associated with increases in swelling. However, injections, blood draws, venipuncture could potentially lead to infection, which has been associated with increased risk of lymphedema. Sauna use has been associated with increased risk of lymphedema, but pet scratches, bug bites, and acupuncture have not. Avoid absolutes with patients. Educate them about the reason for these concerns, and encourage patients to assess their own limb frequently. Observe how their arm reacts when exercising and to activity, to heat, etc., so that they can let you know if they notice any changes in arm volume as soon as possible. Prospective surveillance is the practice of taking those patients at greatest risk and assessing them every 3 months following surgery for the first year and less frequently up to 3 to 5 years. Early intervention with compression is essential. Exercise and breathing can be helpful, and massage and manual lymph drainage may also, but compression is definitely a must. A sleeve should be implemented if there is the slightest increase in volume. Even a 3% increase in volume should trigger the sleeve use. If there is greater swelling, compression bandaging works much better as a method to reduce swelling. When patients are considering returning to exercise, make sure they have normal scapulothoracic motion, and those patients who have had an axillary node dissection should progress slower and start lower. Please see the reference on the PAL protocol for the details of this. Exercise is important for all cancer survivors. There's also a reference article regarding the guidelines for exercise in all cancer survivors in the references. Thank you.